Okay, coming up next is a talk, or rather, a series of talks by three eminent doctors on one of the most happening parts of medicine today, one that has undergone multiple name changes and whose pathophysiology we're still trying to elucidate. So, coming up next is a symposium on MASLD, and we have as our speakers Dr. Arun Kumar Kedia, a consultant physician and diabetologist from LifeWorth Super Specialty Hospital, Raipur, Chhattisgarh. We have Dr. Mohsin Aslam, consultant physician and clinical endocrinologist from the Asian Institute of Gastroenterology, Hyderabad. And we also got Dr. Balaji Chidambaram, consultant physician and diabetologist from Nityashri Balaji Hospital, Kumbakonam, Tamil Nadu. Thank you.
So, good afternoon to all of you. So, on this auspicious Saturday when Disha is being held at Bangalore, this postprandial symposium on MASLD is very important because in this 21st century, the most important chronic liver disease that we are facing is not the hepatitis, but it is the MASLD. And what is important is the revolution that we have in the nomenclature from NAFLD to MASLD, which mirrors not only the importance of keeping metabolic dysfunction at the core of the disease, but also it helps us to understand the clinical importance of screening for metabolic dysfunction in all the patients who have fatty liver, and at the same time preventing the stigmatization of patients by calling them as non-alcoholic fatty liver disease. So this paradigm shift of this terminology of NAFLD to MASLD is very, very important, which occurred in 2023. At the same time, there have been a lot of guidelines on how to screen patients for MASLD, when to screen, how to risk stratify, and how to treat them. Moreover, there is a lot of gap in how to handle these patients, who should see these patients, how do we manage these patients, when to start pharmacotherapy, and when to refer to a specialist. So keeping all these things in mind, we'll have a very lucid discussion with two of our eminent panelists, Dr. Balaji from Kumbakonam and Dr. Mohsin, who comes from AIG Hyderabad. So the topic given is fatty liver on ultrasound. What next? Whether to ignore it, to investigate it, and when to intervene. So we begin with, this is a very common finding that we get patients who come with So we often get reports when patients come with a USG report and we have grade 1 or grade 2 fatty liver. Now that becomes a very important situation for the patients, whether he should take a consultation and at the same time it becomes an important question to the doctor on what he should reply to the patient. So a patient comes to you, Dr. Balaji, and comes with this report of incident fatty liver on ultrasound. So how do you explain to your patients about fatty liver? Do you really explain to him that it is a disease, or do you just go about explaining that it is a part of metabolic syndrome?
Sure. Thank you, Dr. Arun, my close friend. And first of all, I sincerely thank Dr. Manogar for this wonderful opportunity. So, most of the findings, most of the patients, when they come with incidental finding of fatty liver, see, first of all, it's just best understood as a spectrum, not as a disease exactly. So, an isolated finding of incidental fatty liver on ultrasound, it's a just marker of early metabolic just dysfunction. So that's the main thing. It may be either insulin resistance or visceral adiposity or dyslipidemia. So it's just a marker of metabolic dysfunction. And secondly, not everyone with a finding of fatty liver progresses to either a metabolic associated MASLD or a cirrhosis of liver. So a mere fatty liver, it can just get reversed if you have a perfect lifestyle modification or if the metabolic things is being corrected. So it's not a disease specific. So if you just accidentally find a diagnosis of fatty liver, it's a cheap, just investigated choice where we should just go ahead and rule out the metabolic associated other problems.
So would you ignore this report, or would you like to
Never. We just don't ignore the things, but it's a cheaper thing where you have come to a position that we need to evaluate further and just go and treat the things.
So the clear-cut message is that fatty liver cannot be ignored. You have to take it as a marker of early systemic inflammation, and more so ever, it could be the hepatic manifestation of metabolic syndrome. At the same time, we should not make the patient afraid about it. So because not every patient will progress to cirrhosis or fibrosis, but at the same time, you have to also investigate for cardiovascular risk in all these patients, and it could be one of the opportunity for early prevention of further diseases. So as we see that there is a progression of hepatic pathology, so from healthy liver, around 20 to 30% of patients will progress to fatty liver disease, out of which another 20% will progress to NASH, and then out of that 10% will progress to cirrhosis, and out of those cirrhosis another 20% will progress to hepatocellular carcinoma. Now this progression is a stepwise progression. You have initially a few metabolic markers, then these metabolic markers can accumulate with time, and with time there could be a genetic hit or there could be an environmental hit which could lead to fibrosis and further complications of hepatocellular carcinoma. Now here we also need to understand that not every patient progresses. There are some genetic markers, and there is a lot of research going on which genes are responsible for early progression of fatty liver to NASH and hepatocellular carcinoma, and probably we'll have more answers in the future. So over to Dr. Mohsin. Since we have already established that these reports cannot be ignored, so should every patient be referred to a specialist then?
If your patient comes with a fatty liver, and most of the patients, they come with a blood profile done also. So, and like if all the blood parameters are normal, viral markers are negative, yes, it should be managed at primary care level, because the term now has changed from non-alcoholic fatty liver disease to metabolic. So metabolic, it includes all the metabolic components which the primary care physician is treating, and also the patients with chronic liver disease. The studies have shown that the more number of patients with CLD, they die of cardiovascular disease than the liver disease itself. And also it's more commonly associated with diabetes and other comorbidities like hypertension and all. So it should be managed at primary care level, and correcting the fatty liver will also improve the metabolic components, and improving the metabolic components will automatically reverse the fatty liver. If the patient is not improving despite controlling the metabolic components, still the fatty liver is persisting or there is a worsening of liver enzymes, uh, the calculation of the score called FIP score, which takes into account the patient's age, AST, ALT, and platelets, which is a very simple score. If the score is high, even if the score is very high, like if suppose more than 2.67, then directly refer to specialist. But if it is less than 1.3, again we can manage. If the score is intermediate between 1.3 to 2.67, then perform a fibroscan, which can be done again at the primary care level. Again, the fibroscan score is low, less than 8. Again, can be managed with lifestyle changes. And if it is more than 8, we have to refer to a primary care
So,
specialist.
we need to remember that, as I showed in the previous slide, only 20 to 30% of patients will progress to NASH and fibrosis. So what we need to understand is not every patient needs referral, because if you refer every patient to a hepatologist, the patients will have to undergo unnecessary investigations. So at primary care level, 70 to 80% of patients of MASLD can be very well managed by controlling the metabolic factors. We need to risk stratify these patients with the help of various non-invasive tests, and only when we feel that these patients are at high risk, then only we need to refer them to a hepatologist or a gastroenterologist. So this referral is based on certain scores, which we'll be discussing in time to come. But what is important to understand is which patients would require further evaluation after an ultrasound diagnosis of fatty liver. So over to Dr. Balaji.
See, absolutely every patient with a diagnosis of fatty liver on ultrasound, they need an evaluation, but not extensive investigation. So first of all, we need to have a classification of this fatty liver. What exactly? See, if you just see, we need to analyze 4 different categories. The first thing is whether the patient has been associated with any metabolic abnormalities or metabolic dysfunction. Secondly, whether the patient has an history of alcohol intake. Thirdly, any history of drug intake like the steroids and other things for some other cause. Lastly, rule out the other secondary causes for the hepatic steatosis or fatty liver on ultrasound. So routine investigations like liver enzymes, HbA1c, lipid profile, and viral hepatitis screening, all the basic investigations. So these are the things to just have in each and every patient. So, but the common mistake what we do is just see the liver enzymes and just see if the liver enzymes are normal. We think that everything is absolutely normal, but it's not so. So we need to just analyze if even though if the liver enzymes are not, even though it's normal, we have to rule out the other causes, have a complete metabolic profile, other viral hepatitis screening and other things.
So I think history taking will be very important.
Absolutely.
So in the history, we must first of all rule out the history of alcohol, and there are certain norms which have been mentioned for the quantity of alcohol both for males and females. Dr. Balaji, could you elaborate on the quantity of alcohol?
I absolutely have no idea. Maybe
Now it has become 0.
zero.
Now it has become 0.
No, but to classify a patient to have non-alcoholic fatty liver disease or MASLD.
Now that's the reason now MASLD term has been removed and MASLD has come, where the patients with alcohol intake can also have MASLD, but the term then we use is MET-ALD, that is both components of metabolic plus alcohol.
So for that they have classified a certain amount of alcohol.
80 grams of alcohol per week.
So it is 50,
for
less than
females.
50 grams of alcohol.
And more than 80 for males.
Less than 50 and less than 30 for females. If anybody is taking alcohol, it has to be less than 50 grams for males and less than 30 grams for females. Then only you can call it as MASLD rather than calling it alcoholic fatty liver disease.
Absolutely.
So that the thing is, we have to always elicit alcohol history. We must rule out viral hepatitis as the cause of chronic liver diseases, and at the same time we should rule out other secondary causes like drugs, autoimmunity, and environmental toxins also. So these are very important before we label a patient as MASLD. So Dr. Mohsin, you were talking about risk stratification using FIB4. Could you elaborate what is FIB4? How do you calculate?
So FIB4 is again a basic test to look for early fibrosis in patients with fatty liver. It takes into account patients' AST, ALT, platelet count and age. So it's like age into AST divided by platelet into square root of ALT. So as I mentioned, less than 1.3 is normal, 1.3 to 6.2.67 is intermediate, and more than 2.6 is high risk for fibrosis. But again, there's a caveat. Patients age less than 35, more than 65, it's not reliable. And also in advanced diseases, the liver enzymes tend to be normal. So we have to be careful, and further, if we have clinical suspicion, we have to go with advanced tests like FibroScan, which is again a non-invasive test.
So to the audience, how many of you actually do FIB4 scoring in your day-to-day clinical practice? So only 2, 3. So that's the gap that we have in evaluation of MASLD, because despite this test being a very simple, inexpensive test where we don't need to even do mathematical calculation, there is a app available. You just have to enter the data and it will give you the answer. Still, we do not evaluate all our patients for FIB4. So this simple test can actually reduce your unnecessary referrals. As Dr. Mohsin clearly mentioned, that a score less than 1.3 rules out significant fibrosis, and score more than 2.67 rules in significant fibrosis. So it's a very easy way to rule in and rule out. And then there is a indeterminate category where it is between 1.3 to 2.6, where we need to really evaluate further with further tests. So it is very important to understand that FIB4 is an excellent screening test which can be done on a daily practice in all our patients with metabolic syndrome. So Dr. Mohsin, then which patients would go for FibroScan?
Like as I mentioned, FIB score more than 1.3, or in patients who are clinically suspected of having advanced disease, because in those patients liver enzymes will be normal.
Okay. So basically you want to say that not all patients need FibroScan. That is important because FibroScan is not a very cheap test. And secondly, it is not easily available in most of the clinics. It is usually available only at tertiary centers. The equipment of FibroScan itself is quite expensive, and most of the clinics as of today don't have FibroScan machines. So what we need to do is you need to score the FIB4 first, and based on FIB4 you decide which patients will undergo FibroScan. So a bit about FibroScan. It's a non-invasive test, but it's a very quick test to a bedside test where you can diagnose significant fibrosis, and it is reliable, very much reliable, almost similar to MRI. It's very predictive for risk of decompensation as well as complications, and it also correlates very well with portal pressure. So actually it's a very good non-invasive test which has almost replaced liver biopsy as one of the standard procedures for diagnosing MASLD. Now the only caveat for FibroScan is when you have a very obese patient. But now the newer FibroScan machines have Excel probes. Now these Excel probes can be used for even obese patients. So when you order a FibroScan, you have to see the body weight and BMI of your patient and ask the operator to use a proper scan. Second, you have to always understand that if you do this FibroScan test immediately postprandial, then there can be a very falsely high values of liver stiffness. So ideally, there should be a fasting of at least 4 hours before you send the patients for FibroScan, and these patients should not have active liver disease in the form of any active infection. At the same time, these patients should not have consumed alcohol at least for 24 hours before the test. So these are certain things that we need to keep in mind before we order this test, so that we don't get any false positive results. And what results do we get with FibroScan? We get 2 important parameters. One is what is called as a liver stiffness parameter, which we measured in kilopascals. And based on the values, we can divide the fibrosis staging from F0 to F4. And we can also calculate the liver steatosis. So steatosis is measured as controlled attenuation parameter, and the values less than 240 is considered to be normal. Above 240, you have different categories where you can classify the patient into steatosis stage 0 to stage 3. So what we are interested more when we do FibroScan is not steatosis. We are more interested in fibrosis, of fibrosis, because that is going to decide the mortality and the outcome in these patients. So if we summarize all the commonly non-invasive tests that we use for patients of MASLD, the common ones are AST to LT ratio, APRI, that is the ALT platelet ratio index. Then we have the FIB4, and then we have the MASLD fibrosis score. But the most common ones that we have discussed is the FIB4 as the most initial screening test, followed by those patients who have FIB4 more than 1.3 or more, then they must go for a fibroscan. So this is in a nutshell about investigations in a patient of MASLD. Now with that,
but still in obese patient, MR elastography is preferred over even with Excel probes. The data is not fully established, so MR elastography is preferred.
Yeah, that's what I told. When we go for, now we have those advanced techniques for even obese patients. So since you work in AIG, how frequently do you see liver biopsy, and what are the categories of patients who would require liver biopsy even in the presence of a good fibroscan machine?
Liver biopsy, if despite all the results coming negative, despite lifestyle medication changes, medication, patient losing weight, the liver enzymes are still elevated, we go for liver biopsy.
Okay. So one is when the patient does not respond to the therapy. The second most important thing is whenever you do not have a proper diagnosis, whenever your diagnosis is not very clear, whenever there is a discrepancy between your FIB4 and fibroscan, then also to confirm you can go for liver biopsy. But before liver biopsy, I think MRI elastography is now done at most of the tertiary centers. And I think what percentage of patients would undergo liver biopsy at your center now?
Maybe less than 10%.
Less than 10%. So I think liver biopsy is gradually fading away with the advancement of non-invasive scans that we have. So liver biopsy still has to be kept in mind whenever we have discordant results between FIB4 and fibroscan. Now, coming to audience questions. A 48-year-old obese diabetic patient has incidental fatty liver on ultrasound with normal liver enzymes. What would you do? Anyone who could answer? Anyone can just volunteer and speak out. So who would go for A? Raise your hands. None. B? Few. C? So maximum. So I think the first part of our discussion has been successful, that majority have understood that we need to subject these patients for FIB4 because this patient has components of metabolic syndrome. So we move ahead now. So now that we have established that this patient has MASLD, over to Dr. Balaji. When and how should we intervene in these patients?
See, the thing is, nowadays, after the thing of non-invasive FIB4 score, if the FIB4 score is 0.7, I think, the thing is we can just manage the metabolic associated things. And if we correct the blood sugar thing and other things, obviously, and if you focus on the weight loss and other things, obviously we know that the liver fat itself will be reversed based on the things. So the main goal of treating this fatty liver will be the other associated metabolic functions like the glycemic variability, the lipid profile, and also some improvement in the other aspects of the metabolic things. But if you have a FIB4 score of level of intermediate thing more than 3.4 and above, so then we need to have a referral to the hepatologist where they can go for some other procedures where you need to correct the aspect of the fatty liver and other things before prognosis to liver, either cirrhosis or for advanced fibrosis and other things.
So what Sir wants to tell is that the goal of treatment in all these patients would be first is to maintain and reduce all the cardiometabolic factors. So that is the most important thing. as you can see, the goals of treatment would be, one is to improve the cardiometabolic factors. So for that, we need to have glycemic control, lipids control, weight control, hypertension control. So all these 4 metabolic parameters have to be controlled. And then if the patient has fibrosis or NASH, then these patients need specific therapy for which we need to go for pharmacological therapy. So the idea is that not all patients require pharmacological therapy, but all patients require lifestyle interventions. So Dr. Mohsin, can lifestyle intervention alone reverse fatty liver?
Yes, lifestyle intervention, if it's like mild to moderate fatty liver, it can be reversed. Up to 5% weight loss has shown to reduce the steatohepatitis, and 5 to 10%, 7 to 10% has shown to completely reverse steatohepatitis, and more than 10% has shown to reduce the fibrosis also.
So we need to understand this, that even a small amount of weight loss, as Dr. Jayan Panda sir spoke on NEAT, that even a 5% weight loss can transform into tremendous results. So you can have regression of fat from the liver, and if you reduce between 7 to 10%, you can actually reduce inflammation. So there could be regression of the ballooning of hepatocytes in the liver. And if the weight loss is more than 10%, then studies have shown that there can be some regression of fibrosis also. Apart from that, exercise has sub-independent benefits, like it improves other cardiometabolic parameters, it reduces hypertension, it reduces your lipid profile. We need to go for Mediterranean diet to reduce the weight, but what is important is all these have to be sustainable. This cannot be temporary. So the patient needs to be on a long-term lifestyle interventions. So over to Dr. Balaji sir. Would you prescribe SGLT2 inhibitors or a GLP-1 RA or both in these patients?
See, obviously my answer will be no, because not each and every patient with fatty liver we need to go for SGLT2. But if the patient is having associated metabolic dysfunction like freeze, diabetes, or some cardiac factors and thing, obviously GLP-1 agonist, where we have a very long evidence of weight reduction and also additional benefits of extra glycemic benefits like the MASH benefits and also other things, will play an important role. And with respect to the SGLT2 inhibitors, definitely if the patient is having some associated heart failure, or if the patient is having some chronic kidney disease, obviously these class of drugs will have a huge benefit if the patient is having fatty liver and other things. So the main thing is, after the recent ADA guidelines, they just have a say on the usage of GLP-1 agonist and these SGLT inhibitors, because of the emerging evidence of more fat reduction with this particular class of drugs and having some extra glycemic benefits, as I told before, the cardiovascular things. But the cost will be the thing. But after the emergence of generic things, maybe GLP-1 agonist and SGLT inhibitors can be used in each and every patient.
So I think we all agree that GLP-1 receptor agonists have come a long way in the guidelines now for the treatment of MASLD, and they have become one of the most important drugs for management of MASLD. However, we must understand that SGLT2 inhibitors also have a good amount of fat reducing effect from the liver. At the same time, it has cardiorenal protection. So we should not underestimate the role of SGLT2 inhibitors. So those patients who cannot afford GLP-1 RA can be easily given an SGLT2 inhibitor. And for those patients who are extremely obese, where you have patients with morbid obesity, you can actually combine both these drugs also. So this is very important to understand that not all patients will require pharmacotherapy. You need to individualize the patients for pharmacotherapy. So if we see the effects of different agents available on MASLD, you can see that the top drugs are the pioglitazone, the GLP-1 RA, then we have the dual analogs, and then we have the SGLT2 inhibitors. Now all these 4 categories of drugs, you can see that they have significant effect on MASH resolution as well as liver fibrosis. The only important thing that we need to understand about pioglitazone is that there could be weight increase with pioglitazone, and it is contraindicated in patients with stage 3 and stage 4 heart failure. So you need to evaluate the patients before you prescribe pioglitazone to these patients. A very important problem that we face in our day-to-day practice is when the patient comes with MASLD with mildly elevated liver enzymes, and many doctors immediately jump to a conclusion that these patients should not be on statins. So I would like to understand from Dr. Mohsin, would you like to stop statins in these patients with fatty liver?
So there are studies which have shown that with rosuvastatin there is increase in the liver enzymes, but that is very, very mild. And even the studies have shown that with the rosuvastatin there is an increase in the blood sugar. So we are not starting statins in patients with diabetic. Similarly, in such, because of their cardiovascular benefits, metabolic benefits, other pleiotropic effects, and studies have also shown there is an improvement in fatty liver disease with statins. So I will not stop the patient on statins in patients who have fatty liver.
So the message is quite loud and clear that statins should not be stopped in these patients, even if you have mild transaminitis, because this transaminitis is not clinically significant. That is very important. Second, the cardiovascular benefit that you get with statins is far more than the small amount of transaminitis that you get with the statins. So never stop statins in these patients unless until you have progressive rise in liver enzymes. So if you see the overview of the management protocol for MASH, you see that lifestyle intervention remains for all categories of MASLD, whether it is FIB4 less than 1.3 or it is the intermediate or whether it is more than 2.67. Weight loss is recommended in all categories of patients if they are beyond BMI of 23 or if the abdominal circumference is more than 80 for women and 90 for men. Pharmacotherapy for MASH is recommended only in FIB4 category more than 1.3 if the patient has symptomatic liver disease. CVD risk reduction is mandatory for all categories of patients, so that is very important that we need to remember. And diabetes care has to be as per the standards of care with more use of GLP-1RA, SGLT2 inhibitors and pioglitazone as far as possible. However, if the patient is already diagnosed with cirrhosis, then the best anti-hyperglycemic agent would be insulin for those patients. So this is in a nutshell that we need to remember when we treat the patients of MASH. Now, patients with fibrosis, we also need to understand that these patients may require beyond GLP-1RA. So the only drug which has been approved for fibrosis reversal is resmetirom. But resmetirom is not easily available. However, you can get these drugs through pharma people right now. We need to have proper prescription for resmetirom with indications that this patient has F2 or F3 fibrosis stage. But at the same time, these patients would require multidisciplinary consultations. So a hepatologist would be there for referral. We also need to screen these patients for cirrhosis and liver carcinoma. So what is the protocol for following up these patients if they have F3 fibrosis? How frequently would you screen them for liver carcinoma?
For liver carcinoma, we screen once at baseline. We do a triphasic MRI, and then annually we do it a triphasic MRI.
Okay. And how
And we do
frequently
AFP
you do
also.
AFP, yeah.
And we are doing PVCA. PVCA is more specific than AFP.
Okay. So that is very important that you must annually screen them for liver carcinoma. So Dr. Balaji, what are the most important myths surrounding fatty liver which you would like to tell to all your patients?
See, each and every aspect of thing we have many myths. So with respect to fatty liver, so first thing is we people also believe that normal liver enzyme means that liver is functioning normal. So it's not so. Even if the enzymes levels are normal, it's not that the liver is still perfectly normal. So secondly, as people say, if I have a very lean body mass, I will not have any liver problem. So we South Asian people have the thin fat hypothesis where there is a possibility of metabolic associated liver disease, where exactly each and everything. Thirdly, as before itself we discussed, just a mere fatty liver, it will not stay there for a long time and it will not progress further to either cirrhosis or thing. So just it's a finding only, it's not a disease spectrum. It's not so. So if you not intervene at the stage of fatty liver, it will obviously progress to cirrhosis and advanced fibrosis. And as Dr. Mohsin said, statins are not harmful in case of these fatty livers. So statin should be continued in case of fatty liver. And lastly, alcohol is not the only cause for fatty liver. So we are now in a phase where non-alcoholic fatty liver is the most dangerous thing and is the commonest cause for all cardiovascular deaths with respect to the fatty livers.
So at this stage, it is very important to understand that there is a subset of patients called as lean MASLD. Now, this lean MASLD constitutes approximately 20% of the population of MASLD. So that is very important to remember. 1 out of 5 patients that you see with fatty liver may be a lean patient. So just do not rule out MASLD that it is not possible in a patient who is very lean and thin. So in a patient who is lean and thin, who might be still having insulin resistance, you must evaluate them for metabolic dysfunction associated liver disease. That is again very important. And these lean MASLD patients, we cannot give them GLP-1 RA. They might improve with pioglitazone. And then we have one more drug which is DCGI approved in India, that is saroglitazar. So saroglitazar can be given to patients who are lean MASLD. That is important. So those patients where you do not want further weight reduction or you are afraid of sarcopenia, these patients can be put on pioglitazone or saroglitazar. So this again is a very favorite question. Many times we see prescriptions of vitamin E, we see prescriptions of silymarin, obeticholic acid. So Dr. Mohsin, since you stand in a place which is probably the highest center for liver disease in India, what is your take on these drugs?
First, coming to vitamin E, yes, in mild fatty liver disease with mild transaminitis, it is helpful, but we usually don't prescribe it more than 6 months.
Disadvantage?
Disadvantage, again, increased risk of toxicity and also development of blood sugar levels, increased blood sugar levels.
So vitamin E in studies have shown to increase the incidence of hemorrhagic strokes, and it has also been linked to prostatic cancer. So these are the 2 reasons why we cannot use vitamin E for a very long time. Yeah. And diabetes.
In diabetic, yes.
Yeah. Yes, non-diabetic.
And pioglitazone, yes, patient is diabetic, cardiovascular, there is no heart failure. We are using it in a dose of 15 to 30 mg per day, and it has again shown very good results in the reversal of fatty liver and improvement in the liver enzymes. Silymarin, yes, it's a good drug. Also helps in reversal of enzymes and also bringing down the bilirubin levels.
But are these drugs approved? Silymarin?
No, not yet.
So we need to understand that silymarin, obeticholic acid, vitamin E, these are not approved yet for the treatment.
Obeticholic acid, initially it had gone approval, but because of the increased side effects, because of that, it has been again taken back.
So we must understand the risk versus benefits of all these drugs. So just because a pharma company is promoting a drug, do not prescribe these drugs. So there's a lot of future landscape which is evolving in the field of MASLD. Mainly these landscapes are targeting lipotoxicity, inflammation and fibrosis. So these are the category of drugs which are coming up in the future. Resmetirom is already there in the market. There is a lot of trial going on with pan-PPAR agonist called as lenifibranor. Then we have trials going on with FGF21 analogs, and then combination strategies where they combine targets of metabolic disease as well as anti-fibrotic approach. And as I said in the beginning, that a lot of genes are being identified as to which patients will progress faster to cirrhosis. So gene-targeted therapies are also into evolution. So before we end, a quick rapid
And
fire.
also, as Jayant Pandasar mentioned, trials with pre and probiotics and fecal microbiota transplantation is also going on.
So this is rapid fire for the audience. Normal ALT excludes significant disease, yes or no? Should every obese patient be screened for MASLD? Yes. Is fibroscan better than biopsy for screening? Definitely yes. Can fatty liver occur in lean individuals? As I said, 20% patients. Is cardiovascular mortality greater than liver mortality? Yes. This is very important because we often fail to tell this to the patients. Most of the patients who have MASLD will die of cardiovascular disease and not due to liver disease. As I said, only 4% of the patients will move towards hepatocellular carcinoma and 10% patients will have cirrhosis and decompensation. Very important, is coffee beneficial? Okay. So this we need to remember that there are studies which shows that more than 3 cups of black coffee per day can reduce MASH, but it has not been approved in the guidelines yet. Can fibrosis regress? Yes. Is there any magic pill as of today? No. Huh? Resmetirom is so far the only magic pill, but again, it is only not available readily in the market. Secondly, it is only approved when you have significant fibrosis, that is beyond F3 stage. So my final take to the audience: a 52-year-old man with BMI 31, hypertension, type 2 diabetes, incidental fatty liver on ultrasound, ALT 42, AST 34. Would you ignore, would you investigate, or would you intervene in these patients? So the thing is, we cannot ignore, we need to investigate. So we investigate these patients with FIB4 to begin with, and if FIB4 is more than 1.3, we have to risk stratify these patients and subject them to fibroscan if possible. And if the FIB4 is more than 2.67, then we need to refer them to a hepatologist. So that is what we need to understand for all these patients. So before I end, I would summarize with these 5 points that we want everyone to assimilate from today's discussion. Do not ignore fatty liver. It is a marker of metabolic disease and future cardiovascular disease. So assess all patients of your fatty liver as what was described by Dr. Balaji. We need to investigate intelligently using non-invasive tests. No need of liver biopsy. So most of these patients can be very well managed by primary healthcare physicians. Intervene early with weight loss, dietary modifications, and optimal management of metabolic abnormalities first. Then you move on to specific therapies. We need to focus on fibrosis and not on liver steatosis. That is very important because fibrosis is going to decide the future liver mortality. So it is the fibrosis that we are more worried about and not the steatosis. And management is multidisciplinary. So you have involvement of primary care physicians, hepatologists, endocrinologists, if required cardiologists also, and dietitians. So before we end, I would like Dr. Mohsin, Dr. Balaji, if you wish to communicate anything further to our audience. Any key message from your end?
Key message: fatty liver should not ignore, and lifestyle is a key step in reversing the fatty liver. It's the first and the key step. Even the patient is on drugs, lifestyle is most important.
Dr. Balaji.
So just liver is the physiology and the fibrosis is the just other factors. It's the metabolism which is involved. So don't just ignore the biology behind the things. Always don't ignore fatty liver.
So I think the clear and crystal message is that do not ignore fatty liver when the patient comes to you with a report. Do investigate them properly, and wherever required, do intervene. So with that, I thank the organizers of Disha to give us this platform to discuss this very important topic, MASLD, which is the hot topic of 21st century. And now I invite questions and comments from any of the audience.
So sorry, but we're running far behind, right? Okay, thank you.
Pardon?
Okay, just the one question.
Any role of TATCA?
I
TUDCA, Tatka.
I'm not aware. You would like to answer?
No, I never heard of.
I also. Dr. Balaji, have you heard of it? No idea. Thank you, Arun. Thank you, Dr. Mohsin and Dr. Balaji.
Thank you so much, everyone. I would request all three of you to please head to the adjacent area for your pictures and mementos.